Welcome again. We'll start from scratch. I'm Brent Sharpe, Georgia Urology. Thank you for your time tonight. It's amazing. We put a man on the moon in 1962, I believe it was, and we still have technical difficulty in 2021. All right. That being said, so tonight, again, we're going to talk about what we call BPH, or enlarged prostate or benign prostatic hyperplasia. I want to say up front that I enjoy doing these. I enjoy the questions at the end. So please, this is for everyone out there to get your questions answered. Those questions that you have, what you've read, I think it's very important to get those answered. So please ask, because I promise you, you're not the only one that has the question. We'll try to cover a couple other topics as we run through this, and we'll go from there. So that being said, this is myself, and basically I'm a Georgia Urology, the fifth biggest practice, I believe, in the country. Several guys specializing in BPH like myself, and want to educate everybody else. So tonight we're going to basically just look at what is the prostate. It's a very common question we get. We'll look at BPH as we talked about, and then what are some of our treatment options, and try to get into the pros and cons of that decision-making tree that each patient will make for themselves. What I would like at the end of the night is you understand that there are options available no matter where you're at on the spectrum or where you're at comfort level with medicines versus procedures, that you're going to find there's options. And as long as you know the options, then each individual person can make their best medical decision for them. And that's what we want to cover tonight. So real quickly, the prostate. So basically, this is termed as that walnut-sized gland that sits between the prostate, the bladder, and the urethra. You can see here the image at the top. Where that is there a way I can control a screen here, Jolie? I hate to interrupt there a second. Okay, that's fine. So there's a little gland that sits between the bladder, and that wraps around the urethra of the prostate, which obstructs the flow. It mainly is a fertility organ. So again, when you think about what does the prostate do, it helps produce the sperm and semen contents to allow fertility. So what can happen after that if we're done with fertility? What purpose does it serve? Well, basically, I like to say it can only cause problems. It can enlarge.
Dr. Sharpe, it's happening again. If you want to pause for 1 second, I'm going to send you a phone number to dial in. You can mute yourself on here and dial it on the phone.
Okay.
Hold on.
Everyone, for those who can't hear me, just give us a second. We apologize. Jolie's telling me it's a little bit interrupted.
Nope, you're good now. You're good now. Keep it going.
Okay.
I'm sorry.
All right. Everyone, I do apologize. So again, we were talking a little bit about what the prostate does and what it can cause later in life. Again, as I said, it's a fertility organ. After fertility is over with, I like to say it can only cause problems. It can get enlarged and cause problems with the urinary flow. That's what we'll discuss tonight. It can cause prostatitis. That is a term for just an infection of the prostate. And obviously, everyone knows about prostate cancer. That's the other option. Incidence of prostate cancer is about 1 in 9 currently. So let's look at what is BPH. So BPH is benign prostate hyperplasia, most commonly termed enlarged prostate. A lot of people will use swelling. I tend to think of swelling as an inflammatory response, a twisted ankle, etc. This is an acute process where the enlargement of the prostate is the gland itself enlarging that wraps around and constricts the flow of urine. And again, it's not so much swelling. While it's larger, swelling to me is that inflammatory response. So normal size about an 1.5 inches. But again, this is one of those instances where enlarged prostate can really be not related to size. I've got guys that really have small prostates with lots of symptoms. I have people who have really large prostate that don't have symptoms. So it doesn't really matter so much about the size. But what is important is to learn is what BPH is not, okay? BPH is not prostate cancer. So if you leave here with one thing, that's probably one of the most important things, that if you have enlarged prostate, that's not cancer. In fact, actually, I usually tell patients, if you have symptoms of an enlarged prostate, you can almost guarantee that you don't have prostate cancer. BPH is not a risk factor for prostate cancer. So again, just because you have an enlarged prostate does not put you at an increased risk for prostate cancer. And the symptoms of enlarged prostate and prostate cancer are completely different. So again, understanding that they may coexist or exist at the same time, they're not a cause and relationship type relationship. And just because you have one doesn't mean you have the other. Everybody knows the term PSA. So PSA is a prostate-specific antigen. That's the blood test that we do that helps us screen for prostate cancer. Now, obviously, in all workups, as we're going to talk about in a little bit for BPH or enlarged prostate, we're going to get a PSA. But just to understand, BPH and prostate cancer are not distinguished or differentiated by their PSA. It's just a lab that we use that helps us look at the incidence of prostate cancer, or how likely you have prostate cancer, or do we need to do further workup to rule out prostate cancer before we decide to treat your symptoms in enlarged prostate. So again, as I've said before, the prostate wraps around the urethra, as you can see here in this picture. As the prostate grows and wraps around the urethra on the picture on the right, as you can see, the flow of urine is restricted, and that causes what we call lower urinary tract symptoms. So these are symptoms that occur from the prostate enlarging and preventing the flow of urine. And again, we've already mentioned that size does not correlate to symptoms. So a lot of people say, well, what are my symptoms, or what are typical symptoms of BPH? So when I used to teach medical students or residents and nursing staff, et cetera, I always just think about how you go to the bathroom. So when you go to the bathroom, do you get a sudden urge that you have to go all of a sudden? So that's what we call urgency. Do you have to go a lot, more than you used to? That's frequency. More importantly, when you get there and you kind of get your pants down and ready to void, do you have to wait till it comes out? Do you have to stop? How's the flow when it comes out? Does it burn when it comes out? Do you feel like you get empty? Do you dribble at the end? So these are all those symptoms that tell us how symptomatic patients are from their BPH or enlarged prostate. I like to also explain it this way. A closed door scenario. That's what the prostate is. It's closing that door around the urethra. So think about that. The closed door, if we're in a room and we want to get out of the room, the closed door causes obstructive symptoms. I can't get out. I strain. I push. If we work against a closed door to try to get out of a room, like the urine is trying, we're trying to pee against a large prostate, we get a little mad. We get irritated. So we call those irritative symptoms. Those are frequency, urgency, getting up at night. So you have to classify. There are two sets of symptomatology or types of symptoms you get with BPH. Those are obstructive symptoms and those that are irritative symptoms. And they both tell you something different. Number one, obviously the flow, et cetera, is an obstructive symptom. The irritative symptom comes from that bladder being irritated, and that's typically a cause that the bladder is having to do extra work to get the urine out, so therefore it's mad. But what can happen in that situation is if you ignore those symptoms for long periods of time, years, months, et cetera, or you mask them with medications, you can get some damage to the bladder, and over time, that can come back to haunt patients, making the symptoms from the enlarged prostate more difficult to control. So what do we talk about when we talk about BPH and how it affects patients? Number one, quality of life. I think all of us could agree that we're not so much looking about quantity of life, we're looking at quality of life. And the BPH really affects quality of life of men and is not covered on this slide. It affects women. So we used to say, his getting up at night is your problem. And that's what we say to the ladies, again, because again, you getting up at night is affecting both you and your partner, wife, et cetera. So again, about 95% of men are not very happy with a void as they get older. About 50% of people say it affects their quality of life, their activities that they do, i.e. they got to know where the bathroom is, or, on the golf course at hole number 6, they've got to know where they go to the bathroom every time, those kind of things. About 50% of people may have sexual dysfunction due to their BPH. And that's an anomaly we find is like if you treat the BPH, a lot of times those men will report a better and improved sexual function, especially if their BPH has caused them to be on medications. So again, and the last slide, again, it affects the relationships because, again, as we all know, a happy wife is a happy life. If she gets better sleep, she's happier. So we want to make sure that we're looking out for everybody involved in that scenario. BPH is the most common problem over the age of 50. It's about 50% of men over the age of 60. As you get older, it really correlates with age, which is another similarity between ED or erectile dysfunction. So again, about 50% of 60-year-olds, and then it becomes about 70% of 70-year-olds, 80% of 80-year-olds, et cetera. So it really does correlate with age. And again, they're estimated about 14 million men in the US. I think it's about 35 million people worldwide who suffer from some form of BPH. And again, as a plug to have a good, healthy lifestyle and quality and protecting our quality of life is that's controlling weight and our diet, the lack of exercise, all increase your risk for having enlargement of the prostate. So the plug to get out there with a pair of tennis shoes as we still have this great weather in the fall. Medical history. So what are we going to do? How do we figure out a man has enlarged prostate? So number one, we're going to start with your symptomatology. We talked about that. That's that symptom score. As you see on the right side, we call that the International Prostate Symptom Score, or IPSS score. To note, everyone on this tonight can go to the Resume website or almost any BPH treatment site. Usually at the top part of the page is that what we call BPH score, is the layman's term, or the International Prostate Index score. Fill out that score, kind of see where you fall on symptomatology, and those are rated mild, moderate, and severe. Obviously, we're going to do a prostate exam. Now, again, a lot of people say, well, how big's my prostate from a prostate exam? Understand that a prostate exam is only correct about 50% of the time. So a lot of us, as part of the workup, we're going to actually get a true size via an MRI or an ultrasound to know our size, but we're going to start with the digital rectal exam. We're going to make sure you're getting empty. Again, we really want to know that you're getting empty because it is that holding on to urine because of the enlarged prostate. It really puts you at risk for certain things like bladder stones, infection, et cetera. Okay, so once we kind of do that, the other part of the workup that's not mentioned here is usually at some point we're going to talk about a cystoscopy. So what is a cystoscopy? A cystoscopy is taking a little tiny camera and looking into the male penis to look inside the bladder to see how much constriction that prostate is causing around the urethra. That gives us an assessment, and I've also already mentioned the size of the prostate and how big it is. I sum all those up into four basic things. Number one, your symptoms. We talked about that. Pressure study. That is that study where we have you pee and kind of determine the pressure your bladder generates by a special test. That's the urine test we talked about. Cystoscopy, that's looking for shape. How much does the shape look around the prostate? And then the size. So pressure, size, shape, and what are your symptoms are the main things that we look about how to determine the BPH symptoms for men. So then we look about what are some of our options, okay? So again, we first start with the most basic. We're going to run through all these, but again, these behavioral modifications are things you should not overlook. They're behavioral modifications, so therefore they're the hardest to do because we as humans don't like being told what to do, and having your urologist to tell you to cut out the 2 sodas before you go to bed or the 2 glasses of wine, whatever it may be, that doesn't make all our patients happy, but I think it's very important. So fluid restriction is the quickest one I'd like to discuss. Again, I tell my patients you want to stop drinking about 2 hours before bedtime. You still need to drink the same amount. You just need to move it more in the beginning of the day. About 3 hours before bedtime, things that are known to irritate the bladder: coffee, sodas, tea, ice cream, cereal at night, sodas, anything like that that can irritate the bladder. You don't want to do those because if you do those as we get older, as I say, a lot of us can't do things we did when we were younger. You can't have those 2 sodas before you go to bed and expect to sleep all night as the older we get. Obviously, watchful waiting, that's just kind of managing symptoms and tolerating. And that's where we find a lot of men who live. They live and just, I'm watching my symptoms. I don't like them, but I don't want to do anything about it. And I think that historically has been a good mantra until the symptoms got really bad. The problem is we now know is there's some damage that can occur. And if we can get to that a little early, we don't end up with some of the problems that occur later in life. So second is first line therapy. So one of the things that we're going to talk about, that you can do in the beginning. I think most people know medications. There are two types of medications. Those are medicines that actually physically shrink the prostate over time. They take about 6 months to a year to get their maximum benefit. There's a medicine we all probably have heard of called Flomax. It also goes by the name of Tamsulosin. There's Rapiflow. There's also Urethral. These are medicines that relax the smooth muscle in the prostate, bladder, neck to open that channel to allow men to void better. Historically, that's where we stopped with first-line therapy. It was medical therapy. When medical therapy failed, we went to surgical procedures because all those surgical procedures were reserved for the operating room. Nowadays, and with a change in the AUA guidelines, the AUA being the American Urological Association guidelines, we now have two options that are first-line therapy, and that is Resume and the prostate implants or permanent implants, also commonly known as what's called UroLift. So those have moved in the first-line therapy realm because there's a lot of people who either A, don't respond to medicines, B, have side effect of medications, or C, just don't simply like taking medicine, which therefore decreases the compliance. We now have these first-line therapies of Resume and the prostate implants, which help men with their BPH symptoms that don't require you to take medications every day. Finally, if you just look at medications first line, what I'm going to call in-office, minimally invasive procedures for the prostate, is you will find a better improvement of symptomatology typically with the in-office procedures, Resumed and UroLift, versus medications. And also, you don't have the side effects of medications. So finally, then the third line therapy becomes surgical therapies. These are procedures that are done in the operating room typically. The four most common ones are GreenLight laser. That's a very common procedure where a laser is used to vaporize the tissue instantaneously. It's an outpatient procedure. There's an old-fashioned TURP. We typically call these resection, or people will call them a trim job that you've heard about from like grandfather, et cetera. All these procedures do a resection or removal of tissue. They just do it through a different method or different tool. So there's GreenLight TURP. We've talked about the older fashioned TURP, which is a resective TURP. And the newer one is the aquablation TURP. That's using a high pressure automated robot to physically remove that tissue. And then there's prostatectomy. Now, in this sense, a lot of men have heard about prostatectomy, but when you think of prostatectomy, you're thinking of a cancer operation and removing the entire glands. There is a prostatectomy where we're removing the prostate tissue from the inside. It's done through either robotic nowadays, used to be done through an open incision, and that is coring out the inside of the prostate through the belly. And these are for really large glands that people need a lot of symptom control, but again, a much more invasive procedure. Even though both of those are done robotically, they're still in-house inpatient status. So alternative medicine, a lot of people ask us about this. What can I take over the counter? I've read this or that. According to AUA, there's no current dietary supplementation that is recommended for lower urinary tract symptoms or enlarged prostate. Salt palmetto or beta prostate being the most common that you hear about. I will say anecdotally, these do help certain men. As I like to explain it in layman's terms, when you look at these studies, statistically significant, there was no difference. So again, they looked at thousands of patients who took these dietary supplements and there was not a statistical significant improvement from them, but some people reported some improvement. Again, as I like to say, these medicines are probably not going to hurt you. They may help if you like them and that's your treatment of modality, and that is fine. Everybody has to make their own decision for their own care. So watchful waiting. Again, advantages, obviously, as you see at the bottom, it's no anesthesia, there's no permanent implant. Surgical retreatment is not applicable because you're not doing a surgery to start with. However, if you look at it, only 19% were satisfied with the lifestyle change of just watching it. And I don't think that makes a big surprise to anyone. These are just those fluid restrictions that we discussed about. And again, they're not going to have huge improvements, but they will have some. When used in combination, that's where it's very important, using those dietary modifications that we talked about. So medications, alpha blockers, and the other one, again, the one that shrinks is called Proscar, finasteride, Avodart, and dutasteride. Those are those medicines that actually physically do shrink. As we talked about, again, no anesthesia, no implant, you're not doing surgery to start with. Its biggest issue is on the right-hand side, as you see the potential side effects. These sometimes can drop blood pressure and cause some dizziness or lightheadedness, cause some fatigability. Their biggest side effect that men report, especially younger men, maybe 65 and under, no offense to those that are over 65, that they have negative effects on sexual dysfunction. In other words, they may affect the intensity of the orgasm. They almost always affect ejaculatory output. They actually can take it to zero as the most common source. And a lot of younger guys don't simply like that side effect. Also, as we've said, this just treats the symptoms. Yes, it makes your symptoms better. Okay. I saw a gentleman today. He's been on that medicine for 2 years. He's relatively happy. However, his symptoms are better, but we don't know what it really is like from the damage occurring to his bladder. And with his history of urinary retention as an episode, he's a higher risk to having that bladder damage. So we decided to evaluate that, what it's like off the medicines, to get a true assessment. So again, I don't like the term masking the symptoms. It is treating the symptoms, but it is not fixing the problem. And again, I think it's very important to notice that compliance with these medications, plus or minus, some studies tell us that 70% of patients are going to discontinue it after a year. This is the other medicine, the alpha reductase inhibitor. This is the Proscar Avodart. Its major side effect is its issue with sexual dysfunction, and the fact that it actually can cause some erectile dysfunction and lower your sex drive. A lot of men are opposed to that. It does lower your PSA by 50%. I think that's a take-home message tonight. That again, if you're on these medications, if your PSA is 3, it's really 6. You have to understand that. Most all doctors understand that, but I think patients have a responsibility to know their care. Again, these medicines reduce your PSA, so you do need to double that in evaluating it. So what we're going to get into is minimally invasive in-office procedures, not surgery, to treat the BPH without actually resecting or cutting out tissue. So the first of those is Resume. This is what most people call water vapor. In a nutshell, basically, this is where a cystoscope is placed through the male penis and into the prostate. A needle is deployed out into the physical prostate tissue, and steam under pressure is injected into the gland itself. Remember, the prostate is a gland. By doing so, this causes the cells to die, and the bodies will come and reabsorb that tissue. And as you see the progression, the before to the after, the channel that this gentleman or this cartoon depicts, avoiding through that channel, is much larger. So that's how it treats the BPH. It actually causes the reabsorption and shrinkage of that tissue. Basically, it does have very long-lasting effects. We're going to talk about that. It does preserve erectile dysfunction and urinary function, mainly sexual function. Again, it doesn't cause the retrograde or no ejaculate volume. Men like that. It doesn't require daily medication. Regular activities are typically resumed within a few days. Let's see what the next slide is. Okay. So again, about 97% of patients did like this procedure. Its advantage is not anesthesia. Again, we talked about these being done in the office or a surgery center. In our office, we use Pronox. Pronox is laughing gas or nitrous oxide. We're actually proud to be the practice that brought that to the state of Georgia. Currently redoing some of our data. We have one of the largest series of use of Pronox or nitrous oxide in all of urology. So it allows you to have this procedure without the general anesthesia, the risk of those procedures, that in and of itself. It also does not have a permanent implant. There's a lot of people which like that aspect, that they're not having a permanent implant placed there to treat their BPH. And I think what's important is the last part of this, the surgical retreatment rate. And I will explain it to start with. This is a trade-off, okay? I'm going to get to that in a second. So if you look, this slide can be updated. I think it's been updated now to 5 years. If I'm not mistaken, it's 5.3% of people needed retreatment 5 years later. So again, this surgery is standing the test of time better than anything we've ever had in what I call minimally invasive BPH treatments. Historically, there's been an indigo laser used in the office. There's been microwave therapy. There's been TUNA, which is radio frequency ablation. These are all older procedures that are no longer done. But the reason they're no longer done is they did not stand the test of time. Both the Resume and the UroLift are standing the test of time better than anything we've ever had. And again, the retreatment rate for the Resume is about 5%. If you look at what Resume is and what to expect, Resume is going to cause that inflammatory response. So the trade-off is a little bit less retreatment rate, but you're going to have a catheter for a couple extra days. It does cause a little bit of an inflammatory response. So you do get some swelling, and you're not going to get quite an instant result. Okay, so there's where your trade-off is again, it doesn't typically make symptoms much worse. It don't get better. Use it for a few weeks, but again, the retreatment rate is less. So the prostatic urethral lift, commonly known as UroLift, is another surgical procedure. Again, does not require anesthesia. There is a permanent implant that's placed. This is basically the prostate tissue is wrapped around the urethra, as you see me depicted by my hands. And what that lift will do is open the channel. This pushes the tissue out of the way. And by doing so, opening that channel, the flow of urine is better. Still get some mild discomfort in the prostate, just like the Resume. Lasts anywhere from 2 to 4 weeks, which is about the same as Resume, maybe slightly less. But again, if you look here, your retreatment rates are a little bit higher. So again, I think that when you become to those men who have larger prostates, there is a limit on what a UroLift can treat as far as size-wise. In my opinion, there is variation if you talk to different individuals. However, I would say if you've got curtains in your house and you want to push those curtains back, the bigger and the heavier the curtain, the less likely the device is to open those curtains. So again, when you get into prostates that are 70, 80, 90 grams, I think the Resume can treat those patients minimally invasive in the office, as opposed to the UroLift. It's in those men who have your typical 20 to 50 gram prostate. It basically comes down to a patient preference. What are the side effects of those individual treatment options, and what each individual patient wants to do for their self. We mentioned real quickly GreenLight laser. So the GreenLight laser is what we call a TURP. It is actually physically removing tissue. It does require general anesthesia. It doesn't have a permanent implant. It's using a laser to vaporize that tissue instantaneously, and by doing so, opening the channel. It is using a heat mechanism, so you do have the added risk of what's called a scar. So you can develop a scar where that resection or removal of tissue is. Do have to have a catheter. It is done in the hospital. You do typically get to go home the same day. So, and you can see here, retreatment rates are about 5% at 5 years. So that's about what Resume is. I think if you look at long-term data and you just talk about TURPs or resection, removing tissue in the operating room, they're going to have about a 10% over the lifetime retreatment rate for most patients. So again, its longevity may be slightly better than the newer data or newer procedures. We just don't have that data. Again, Resume has about 5-year data, and UroLift has just over that also. So it's not fair to compare quite those minimally invasive options to the GreenLight in longevity, because we just don't have the data. But for the first 5 years, it's about the same. Transurethral resection, this is what, again, an actual loop, what we call a loop, or a piece of cutting device is used with a cystoscope to physically scrape or remove that tissue, cut it out. Again, very similar to GreenLight laser. You actually see a little bit higher retreatment rates, so that's why most people tend up having something like a GreenLight laser as opposed to resection. What is not mentioned or a slide on is what the newer procedure called aquablation TURP. That is it's the first automated robot that uses a high pressure water jet to remove the tissue. Again, don't have 5-year data on it, does require general anesthesia, but it really can treat very large glands. I mean, 150, the largest gland I've done so far is 270 grams. Again, to put that in reference, most men are about 40 to 50-ish, okay? And it can treat them in under an hour, whereas a TURP, transurethral section, as you see on this slide, or a GreenLight, that may take an hour and a half to 2 hours to do. So there are some advantages for very large prostates for the newer procedure called aquablation, which does not have a slide on. Prostatectomy, again, that is physically removing the inner portion of the prostate via either an incision in the prostate or belly, or now what most of us do them is robotically. So we use the Da Vinci robot to go in and remove the inside part of the prostate through the bladder. Has excellent surgical retreatment rates, as you see here. Does have a little bit more issues with the retrograde ejaculation. and sometimes can require blood transfusions. However, with the Da Vinci robot, that is a very uncommon event. It was much more common when we did this to an open surgery. So a lot of people want to know about what insurance coverage is. And again, that's the advantage of having a larger practice and having those resources available to us. When you go through the workup, if you come see us at Georgia Urology with enlarged prostate symptoms, and we walk through the symptoms, the cysto, the size, and figure out what surgical procedure or minimally invasive option such as Resume that you are interested in, our office will simply make sure that those are covered, and we provide the documentation to your insurance company. So that's usually not an issue. Almost every one of these procedures is covered through insurance. Again, these procedures have up to 5-year data, so they're well accepted. And that usually is not an issue at all, but we have mechanisms to work through that. Okay. So again, here's where we get the best part of my, where we get into some of the therapies. Just to quickly review, BPH is enlarged prostate. Again, once you're past fertility, the prostate can only cause problems. And then again, we've talked about these at length. I think I want to mention just to real quickly, when you talk about BPH enlarged prostate, I've touched on it a little bit. These symptoms cause your bladder to do extra work. You may not notice that in the beginning. In fact, actually, if a lot of men who treat their BPH go back and say, well, I didn't realize how bad my symptoms were until I had some surgical treatment or minimally invasive option to treat my BPH. While those symptoms are there, the damage can occur. Your bladder can become replaced with scar tissue or what's called collagen. And I like to use the analogy, the bladder's a muscle. And everybody out there thinks, well, gosh, if my muscle has to do extra work, like my bicep or my tricep, and I get a big dumbbell and I lift extra weights, I'm going to get a bigger bicep. It's going to be stronger and better. And that is very true. However, the bladder muscle is different. As it does the extra work, it doesn't build a bigger, better bladder. It builds a bigger bladder, but the tissue, the fibers, the squeezing capability of the bladder, those muscle fibers, become replaced with collagen, that scar tissue. And if anybody's got a scar and you look at that tissue, it doesn't have the elasticity, the stretch, it doesn't have the function of the normal tissue. So in those people who come to us very late, where they've ignored symptoms for years and years, there is a situation where their bladder can become so damaged and they're in what we call retention. Urinary retention is holding on to urine so that you don't get empty, that their bladder becomes so damaged that doing a procedure to treat the enlarged prostate, i.e. opening the door, will not work. In other words, bladder has no squeezability to it. So my take-home message from the patient side is go to the internet, do your research, make sure you look up that BPH score, fill that out, see where you fall. And then if there are mild to moderate symptoms, please go see somebody. Again, we have lots of us who are interested in this, who do this on a very high frequency. Georgia Urology thing was Center of Excellence, those who are becoming close to them, as myself. And we do this very, very frequently and can do it with high success rates. Okay. This is just a hotline for reimbursement. Again, we take that care of that for you in our office if this is something you want to do. So I think ultimately the next step, again, like I said, fill out that score, know your symptomatology, and then really assess it. For those of you who are out there on medicines, as I told the gentleman today, you may want to stop the medicines for a few weeks. Really see how bad symptoms are, because again, if you don't notice a huge change and you're happy on the medicine, that's great. But if you know the marked difference, then you can say, look, maybe this medicine is really helping, but it's masking the symptoms as opposed to treating the problem. And I may end up with some of those damages. Lastly, again, if you treat or mask the symptoms, the ones that become from the bladder damage, that replacement of the smooth muscle with the collagen, tend to be the irritative type symptoms. Remember back, I talked about obstructive symptoms and irritative symptoms from the prostate. The ones that come late are the more problematic ones, and that's the irritative. Frequency, urgency, having to go all of a sudden, getting up at night, and even some leakage. Those symptoms become much more difficult to treat. So if you treat the obstructive symptom in that patient, the irritative symptoms are more likely to persist. And that's why we want to prevent the damage to the bladder, or what I call preserve the bladder health, so that you're not in those patients where when you treat the BPH,